We're continuing our series of tutorial videos to assist you in your interpretation of your hormone results from Precision Analytical. And in this session, we're going to be discussing androgen metabolism. So on the hormone metabolite assessment on page 1 of your report, you will see a listing of androgen metabolites there in the middle of the page with the reference ranges and whether the results are below range, within range, or out of range. And then on page 2, you'll see the graphical representation of how those hormones look relative to not only the reference range but relative to each other as they sit in the hormonal cascade. So if we start from the top, we'll note that we're not measuring DHEA, which is sometimes a common misunderstanding with urine testing. We're actually really more reflecting the sulfate DHEAS, which there's a lot more of in blood, and when you look at urine, what we're really measuring is total DHEA. But that's a little bit misleading because it's so predominantly the sulfated version of DHEA that's really what we're reflecting in the urine levels is DHEAS. And so we're going to want to look at that, and that's an important metabolite, and has been shown to be higher in, for example, older individuals that are healthier. So usually that's an important metabolite to be looking at in your patients, both male and female alike. In the male, that's going to be made by the adrenals and by the gonads, more so the gonads than with the female, and then with the female, again, it's going to be made by both. But as you get into the postmenopausal phase, all of these androgens, as the ovaries give way, are going to be made by the adrenal glands. So the adrenal glands making DHEA, it's making DHEAS, as well as androstenedione, which can then turn into testosterone. And as I said, for postmenopausal women, that's the predominant source of androgens is from the adrenal glands. So we're looking at DHEAS. We're also looking at, of course, your primary androgen, testosterone, as well as its 5-alpha metabolite, dihydrotestosterone, or DHT. And this one's gotten a fair amount of press because it's a more potent androgen, so it's about 3 times stronger than testosterone. And that's something that we're going to want to look at in terms of women who have symptoms of excess androgens, maybe acne, increased facial body hair, that sort of a thing, as well as it becomes important in males with respect to prostate cancer risk and things of that sort. And that's a pretty complicated picture, as they've seen that people who block this conversion of testosterone to 5-alpha DHT with a drug like finasteride, they get less prostate cancer, which seems good, but then when you dig a little further, you find that those who get prostate cancer in that part of the group are much more likely for it to be fatal, so they get more aggressive types. So there are other metabolites down this pathway that are actually favorable in terms of preventing aggressive prostate cancer. So this is a complicated topic, but we want to be looking at more than just testosterone as we try to examine where a patient's at with regard to their androgens. So going further down the line, we can see the DHT metabolite, 5-alpha androstenedione. And what's noteworthy here is, the gonads are typically making testosterone, particularly in a young, healthy male. And then the conversion to DHT does not happen within the gonad, so that's happening usually either in the liver or even more extensively in the periphery. So in the target tissue themselves, there's this conversion to DHT, and oftentimes within that same cell, it gets converted or deactivated, really, to the 5-alpha androstenedione. So that can be a good marker as well of DHT production, although some of it does come also from DHEAS. So we want to look at the entire metabolism of androgens, and one piece of that is actually estrogens. We know estrogens predominantly for their role in females and reproduction and that sort of a thing, but all estradiol is converted from androgens initially. So testosterone gets converted to estradiol, and androstenedione is converted likewise to estrone. And so that's part of the testosterone picture, is when we've got overconversion, as in this person's case, they're making a lot of estrogens out of testosterone. And in males, that'll happen mostly in the periphery, very much so in adipose tissue and fat tissue that have a lot of aromatase which is the enzyme that's responsible for that conversion. So we want to look at the whole picture to see what's going on with the androgens. And getting in even more detail, we talked about 5-alpha reductase and how that can play a role in terms of the production of DHT from testosterone. And so in the 5-alpha reductase portion of the report, we can look at this in a little bit more detail in that there are many hormones that are metabolized by these. Androstenedione, testosterone, as well as cortisol, and actually progesterone as well, are metabolized by competing enzymes, 5-alpha reductase and 5-beta reductase. And so the 5-alpha reductase is going to make more androgenic metabolites. So androsterone is significantly more androgenic than is etiocalanolone. Likewise, 5-alpha DHT is highly androgenic, whereas 5-beta DHT is not. And so we can see oftentimes a theme throughout this. So for this patient, for example, the 5-alpha metabolites, androsterone, is lower within the reference range than is etiocalanolone. We can see the same theme in the testosterone metabolites as the alpha is lower than the beta metabolite. And again with cortisol, which these metabolites are not androgenic at all, but it does show the similar pattern of these same enzymes that are making alpha DHT and beta DHT, and in this one, similar to the other metabolites, we're making more of the beta. So the overall activity is a little bit lower on this one for 5-alpha reductase. We're actually favoring the 5-beta reductase. So for patients where this is an issue, in terms of a man who's maybe trying to look at issues of prostate cancer risk, or a woman who's maybe dealing with some issues of excess androgens in terms of the symptoms that she's looking at, this can play into that in terms of that excess production of DHT, and so we want to look at that. And in some cases, this doesn't have as much relevance. So if you have any questions, patients, on specifics as far as your results, please do refer those back to your healthcare provider. And we hope you've found this tutorial to be helpful in terms of understanding how to interpret some of these results. And we hope you'll also see our other educational videos on other hormonal topics throughout the report that we've got here, looking at estrogens, progesterone metabolites, as well as the adrenal metabolites.